Okay, let's oh, this is steps for patient contact. I don't have to wash or clean my hands before the talk, right? No, something else. All right. So I'm going to talk to you about type 2 diabetes, which, as you undoubtedly know at this point, is the most prevalent type of diabetes in the world, accounting for somewhere in the neighborhood of 90 or 95% of instances of diabetes, with, as you're going to see very shortly, prevalence and incidence rising at an alarming rate for reasons that we'll discuss. So in order to understand a little bit about what I'm going to show you, you need to see this chart. You're undoubtedly, again, familiar with the idea of body mass index, which is a surrogate for adiposity. It is the ratio of weight in kilos over height in meters squared. And here you can look yourself up on this if you care to do so. And I don't see any major offenders in the audience, but you can. This is useful in a gross sort of population-based assessment of individuals in a population or groups in a population for degrees of adiposity. On an individual basis, it's a little bit rockier because there are individuals who have very high BMI because of high muscle content, like professional athletes, and there are other individuals who are sarcopenic, so to speak, so that the BMI, even though it's low, reflects a relatively higher amount of body fat. So be careful with this. But again, as a actuarial tool and as a way of grossly assessing degrees of adiposity, this works reasonably well. I should mention, here are the sort of guidelines for its use. BMI 25 to 29.9 is overweight. Under 25 is normal weight or normal degree of adiposity. 30 to 40 is obese, and over 40 is extreme or morbid obesity. So here's what's been happening. You guys have seen these before, I think, in terms of the prevalence of obesity and diabetes in the United States. So here is the United States in 2001, and the BMI here greater than 30 is scored on this sort of color chart with regard to the percentage of adults in that state who have BMIs that are scored here, as you can see. And notice that the prevalence of obesity moves in pretty much lockstep with this in terms of the prevalence of individuals who have, this is almost entirely type 2 diabetes. And here is 2010, a mere 9 or 10 years later, and you can see that things have not gotten better, and that now the number of states with greater than 26% of the population obese is actually the majority of states, and the prevalence of type 2 diabetes has gone up accordingly. These two disorders go in lockstep for reasons that we will come to in a moment. It's also interesting that if you look at the extremes of obesity, remember BMI greater than 40 is extreme obesity, or greater than 50 is sort of industrial level obesity. And you can see that the prevalence, the fraction, the proportion of these has gone up even more remarkably at the extremes of the distribution of BMI. Partly this is a consequence of the way Gaussian curve is shaped, but it also suggests that there are individuals in the population who are even more susceptible to whatever the consequences of whatever is going on in the environment that's driving the obesity so-called epidemic. There are some individuals who are exquisitely sensitive to this. There likewise are individuals who are exquisitely sensitive to mild or modest increments of body adiposity in terms of conveying a risk of diabetes. So this shows you this in another way. So here again are the cut points based on BMI. Normal weight, overweight, obese, and here are men and women, and it shows you the age-adjusted relative risk of being a type 2 diabetic contingent upon your BMI. So even as the BMI crosses the threshold towards overweight, women already have an 8-fold higher risk of being diabetic and men about twofold. So even very modest amounts of extra body fat above this sort of null zone down here in very skinny individuals is enough to increase your risk, and then it begins to take off exponentially, so that as you cross the obesity threshold, which is what we're talking about on those maps, women have a 27-fold increase in relative risk, and men about a 6.5-fold increase in relative risk. Part of this is due to the fact, again, that I alluded to earlier, women per unit of BMI have more body fat than men do. So women are actually are fatter for any BMI than men are. Sorry. This you can compare with sibling risk, which is if you've got a sib with type 2 diabetes, what is your risk of having the disease? It's about 4 to 6-fold increase. But if you're obese, even regardless of this, obviously the risk is much greater. So obesity is the entry point for many individuals to the development of type 2 diabetes. And you'll see, I'm going to come back to this repeatedly, that if we could prevent or mitigate obesity, much of the diabetes that I'm going to talk about would go away. The single most effective vector into this epidemic would be control of body weight. And if we knew how to control body weight, I'd be here to tell you about that. Unfortunately, haven't quite figured that out. So here are the latest figures. I actually looked these up the other day. There are in the United States 29 million individuals who have diabetes. This is 9.3% of the entire adult population. Those who are diagnosed of this group of 29 million is 21 million. So these are individuals who know they have the disease. There are another 8 million individuals who have it and don't know it. So about 27% of the individuals who have diabetes are undiagnosed. And you might fantasize, I think, but you'd be wrong, that if you don't know you have the disease, the consequences of it don't count. The clock starts ticking once the diagnosis is made, and unfortunately that's not the case. So the consequences of diabetes for eye, circulation, and so forth that I'll come to in a moment, that clock starts as soon as the physiology starts, not when the doctor makes the diagnosis. Note also that among the diagnosed are about 208,000 individuals less than 20. So the number of children with type 2 diabetes, which 10 or 20 years ago would have been almost a novelty. We would have taken you as students to see a type 2 diabetic 10-year-old. Now these guys are starting to fill up the clinics, again, because children are becoming increasingly obese as a result of whatever's going on in the environment to enhance the prevalence of obesity. Now, this will give you a sense of the race ethnicity distribution of this. It's not equally distributed in terms of the age-adjusted, again, percentage of individuals. This is, again, over 20 or older who have diagnosed diabetes in the United States. So non-Hispanic whites, Caucasians actually have the lowest prevalence in the United States. Asian Americans, Hispanics, non-Hispanic blacks, and American Indians or Native Americans and Inuits have the highest prevalence of this disease. This difference bespeaks largely, I think, genetic differences in those populations, but the genes that are conveying this difference remain unknown at the present time, but undoubtedly would be helpful in terms of allowing us to get some additional insight into the genetics of this disorder. And I'm going to come back to the American Indians for you in a moment. So here's what's going on internationally, which is certainly, unfortunately, no better. So here are the incidence rates or prevalence rates for diabetes in 2010, and below the predicted prevalence in 2030 if the current rate of increase continues. So the United States will have 53 million diabetics by 2030, a 42% increase. You can read this as easily as I can, and you can see that there are areas of the world in which there are going to be even larger fractional increases in the prevalence of the disease, such as in the Middle East. These constitute, in addition to the misery that's caused by the disease, enormous burdens on the health system and on the finances. And some of these countries, and in fact some states in the United States, could be bankrupted by this process, again, unless we figure out how to stop it. Down here, you can see the number of individuals in these various parts of the world affected. You can see the diabetes mellitus here in blue and the impaired glucose tolerance, which we'll come back to. These are the people with incipient diabetes shown in red. So here is the sort of description of the disease, which if you read the older literature is often referred to as non-insulin dependent diabetes mellitus. So it represents 90 or 95% of all diabetes. In certain parts of Northern Europe, where type 1 diabetes is more prevalent, the proportion may be closer to 90, but in the United States, for example, and most other populations, it's 95% or more. It is, as I'm going to come back to repeatedly, primarily a beta cell diathesis, meaning an underlying problem with the beta cell that is exacerbated by obesity and physical inactivity. If you remember nothing else, this is really where the money is in terms of understanding this disease. There's something wrong with the beta cells, and whatever that is, whatever you inherit or acquire as a result of intrauterine or postnatal processes, you exacerbate it by obesity and muscular inactivity, leading to the full expression of the disease. If you have the diathesis but don't get obese, as you'll see, you may not get the disease. It is characterized by relative hypoinsulinemia. So unlike type 1 diabetes, where you make virtually no insulin, as you'll see, these guys make insulin, but they don't make enough to overcome the consequences of their adiposity and resistance to the action of insulin. There's a very strong family history of this disorder and a very strong associated history of gestational diabetes. So one of the easiest ways to figure out if somebody is at risk for type 2 diabetes is just to ask the question, are there other diabetics in the family? Is anyone taking insulin? Are there people on oral medications for diabetes? This will give you a very clear and statistically powerful insight into risk. There's race, ethnicity differences, as I just pointed out to you, and I showed you their sort of relative preponderance. And as I mentioned, all of these groups are showing increases in type 2 diabetes in childhood, due, I think, to a combination of the presence of the genetic and developmental issues exacerbated now by increasing levels of adiposity. So this is in your handout, and you can look at it at your leisure. There are sort of three major ways of scoring an individual for whether or not they have diabetes. The sort of, I guess, conventional way is fasting plasma glucose. So if you have a fasting plasma glucose, meaning overnight fast, 12 hours or so, if your blood sugar is less than 100, you're normal. If you have a blood sugar up to 126, you are pre-diabetic. This would be somebody with potentially impaired glucose tolerance. And if it's over 126, you have diabetes. If you give an individual an oral glucose tolerance test, this is usually a 75-gram oral load of glucose. The criteria are as follows. You should not have any sugar above 140. If it's under the 200 but above 140, you are considered to have impaired glucose tolerance, meaning you're on the way potentially to developing the disease. Over 200, you've got it. And lastly, very powerful tool for tracking long-term blood glucose, the hemoglobin A1C, which measures glycosylated protein, in this case hemoglobin. You can do it with other proteins as well. This tells you what the chronic level of blood sugar has been in that individual for the antecedent 5 or 6 weeks. Less than 5.7% is considered normal. 5.7 to 6.5, again, is on the threshold. Over 6.5, you're diabetic. I think most clinicians would not make a diagnosis of diabetes simply based on an A1C, but might use it as a very rapid screen, and if there is any indication of trouble, go to one or the other of these other tests. So what about the complications? Why is it not good to have diabetes? I don't think any of you thought it was, but just to sort of give you a feel for this, this is a nasty disease because it erodes almost all areas of the physiology of a human being. And as I indicated, the fact that you don't know you have it doesn't mean you are excused from these consequences. So cardiovascular disease and stroke, 2 to 4% increase among diabetics, 75% are hypertensive. It's the leading cause of blindness between 20 and 74. Kidney disease, 44% of all new cases of renal failure. CNS and peripheral nervous system phenotypes in about 70%. This exacerbates almost certainly the onset of Alzheimer's disease, probably Parkinson's disease, among other things, and by interfering with the peripheral nervous system and the autonomic nervous system impairs circulation in the extremities, ergo 60% of all non-traumatic lower limb amputations in the United States are due to diabetes. A lot of periodontal disease, they lose their teeth. Pregnancy with elevated blood glucose leads to fetal malformations, and there are psychiatric consequences of this, not only in reaction to having the disease, but probably primary effects on the central nervous system. So these complications that I just alluded to can be put into two sort of large categories of mechanism. One is due to insulin resistance, and this is conveyed in large and medium-sized vessels such as the coronaries, the peripheral circulation, and the brain, where you get ischemia of these organs. Obviously, if this happens in your coronaries, you have heart attacks. Peripherally, you lose limbs, and in the brain, this causes stroke. And the blood sugar elevations, aside from the consequences of the insulin resistance, and we know this from tracking, for example, individuals who have type 1 diabetes who are not insulin resistant, this tends to cause small vessel disease, so kidney disease, glomerulopathy, blindness, and the peripheral neuropathy that's associated with diabetes. This is a very general summation. I think it's a good way to sort of fix your thinking about this, but there's increasing evidence that the hyperglycemia is bleeding mechanistically into some of the things that were originally attributed solely to the insulin resistance phenotype of these individuals. So here's the sort of cost that I alluded to, and you can read this very easily. So the obesity costs us about $215 billion, the diabetes $218 billion, and the resulting cardiovascular disease about $400 billion. And if you add this up, you're now getting a very substantial fraction of the entire healthcare expenditures in the United States. So if we could get a handle on this, we would obviously have a major impact, not only on the misery that's associated with this, but on the tremendous cost to the healthcare system and to our productivity in terms of lost revenue. This is a nasty business. So I alluded to this earlier, but here it is shown to you schematically for your edification. So there are genes that predispose to obesity, and most of these genes are central nervous system genes. I'm not here to talk to you primarily about obesity, but we know a lot about the genes, but we don't know exactly how they operate to produce the obesity. But virtually all of the big genetic analyses show that brain genes, primarily or majorly hypothalamic genes, are the predisposing mechanism, and these are then exposed, or they are the predisposing genetic mechanism. You expose these to the environment, meaning people who have access to a lot of food and are inactive and other things that we don't fully understand, and you get obesity. And that obesity you can consider to be the environmental trigger as I've said repeatedly, for type 2 diabetes. So there are predisposing genes for diabetes, and as I mentioned before, these are primarily beta cell genes. These have genes having to do with the development of beta cells and the function of beta cells. I'll come back to this in a moment. And those genes in the environment of an obese individual who is insulin resistant produces type 2 diabetes. So about 80% of diabetics are obese, and about 50% of obese individuals are diabetic. This is the sort of deadly interaction that produces type 2 diabetes. And again, I said it before, if we could do something about this, we would get rid of an awful lot of that. So here are some of the endocrine disorders that exacerbate, derange, or exacerbate glucose homeostasis in the sense of deranging it. I put these here so you would appreciate in your clinical experience that these are disorders that will drive up the blood glucose and need to be considered when you see an individual who is hyperglycemic. And I would say that in the majority of instances, excess thyroid, excess glucocorticoids, some of this coming about from the individual's own adrenal glands, quite frequently from the administration of glucocorticoids for various diseases, acromegaly, which is excess growth hormone, pheochromocytoma, which is production of catecholamines, and pregnancy. You will see individuals who are hyperglycemic in this context, and what you should think, I think, when you see this is it may not be that endocrinopathy per se, which is the ultimate mechanism of the hyperglycemia, that what you are seeing is an endocrine derangement which is bringing out the diabetic diathesis in this individual, so that even if you cure this endocrinopathy, you should remember that this is very likely an individual susceptible to long-term problems with glucose homeostasis. This is particularly true in pregnancy, where many women who develop hyperglycemia during pregnancy will subsequently go on to have full-blown type 2 diabetes. So don't think you've fixed the problem when you make a clever diagnosis of hyperglycemia due to hyperthyroidism and you treat the hyperthyroidism. Keep track of these people. So here is sort of beta cell biology 101. This is a beta cell in schematic representation. Glucose comes into the beta cell through a glucose transporter. I'll say more about the glucose transporters in a moment. It is metabolized through the Krebs cycle to produce ATP. The ATP interacts with the potassium channel here, which has a couple of major components to it. This is a fascinating structure in and of itself, and I commend it to your attention just for its sort of elegance, if you have time to just look at a picture of this. But in any event, the presence of ATP closes the channel. It actually is sensitive to the ratio of ATP to ADP, closes the channel, which causes the beta cell to depolarize, allowing calcium to enter the cell. There's also intracellular stores of calcium. This intracellular calcium causes the exocytosis of insulin. So in a very simple manner, this is the way that glucose homeostasis is regulated through the beta cell. It sees the glucose in the circulation, releases insulin. The insulin interacts with insulin receptors, which happen to be present on the beta cell in a sort of fascinating autocrine feedback mechanism, but also obviously are present throughout the body. And we'll come back to this in just a moment. The insulin receptor activates a series of protein kinases, which I'll also tell you about in a moment, which in turn affect the production of insulin within the beta cell and other aspects of physiology outside the beta cell. These are transcription factors that play a role in the expression of insulin, and all of these are in fact members of a group of molecules that are mutant in a relatively rare form of diabetes called MODY, maturity onset diabetes of the young. mutations in these genes account for about 5% of extant diabetes. These look more or less like type 2 diabetes, but in fact have a single gene as their mechanism. I'll mention this again in a moment. And here is how insulin behaves in the periphery. So here's that insulin receptor again in a cell. It could be muscle, liver, brain. The engagement of insulin causes phosphorylation of the receptor. This phosphorylation in turn causes phosphorylation of downstream molecules, these insulin receptor substrate molecules, and molecules that are important in this PI3 kinase pathway that I mentioned. So there are two major effects of insulin in homeostasis. I mean, obviously there are tomes written about this, but on this side, what you see is effects primarily on glucose and glycogen metabolism in cells like muscle and liver, which are conveyed by effects on glucose transport. So there are glucose transporters like the one that I told you about with regard to the beta cell, but slightly different in their structure, that then permit glucose to enter that cell. And on the other side here, through the MAP kinase pathway, are effects on gene expression in general and major effects on cell growth and differentiation. So you can sort of think about insulin as having two major physiologic effects. One is on glucose homeostasis in cells, and the other is effects on growth and cell differentiation. So here is the glucose transporter story. The glucose transporter 1, which is actually expressed primarily in the brain, sits on the cell membrane at all times. But glucose transporter 4, which is a major transporter of glucose in these other organs that I mentioned, is sitting intracellularly, waiting for the insulin receptor to see insulin. And when that happens through that PI3 kinase pathway that I mentioned to you, these glucose transporters are moved to the cell membrane. So the engagement of insulin in most cells actually drives the transporter to the surface of the cell, where it takes up the glucose, and the metabolic use of glucose then proceeds along sort of conventional biochemical lines. This is why insulin obviously is so critical to the peripheral action, or the ability to metabolize glucose. This is the reason for it. It's not that the insulin itself has any primary effect on this. It's conveyed primarily by allowing glucose to enter the cells. So here, in a sort of grand schema of this, taking it out to the level of the body, is the following. So let's start with plasma glucose. The glucose interacts with the beta cell in the way that I mentioned, and insulin comes squirting out. So the insulin has effects on skeletal muscle, where it enhances the uptake of glucose, and it suppresses the release of free fatty acids from fat. These are two very critical actions of insulin. And it also goes to the liver, where it suppresses the production of glucose. So if you want to think about insulin in a very sort of global way, enhances glucose uptake in skeletal muscle, suppresses glucose production in the liver. This leads to a lowering of blood glucose. There are other effects that are shown here, but they're not, the major ones are the ones I just told you, in addition to the suppression of lipolysis. So here's an interesting little sort of factoid about insulin, which has actually clinical relevance. So if you look at the sensitivity or the responsiveness of various biochemical processes in the body to insulin, the inhibition of lipolysis that I just mentioned is the most sensitive, followed by the inhibition of hepatic glucose output. And it takes more insulin, actually, to drive uptake of glucose in muscle, for example. So very low doses or lower doses of insulin will suppress two of these mechanisms, but to actually move glucose into tissue takes additional insulin. And you see this physiologically when you attempt to treat patients with this molecule and its derivatives. There are other interesting things about insulin homeostasis and glucose homeostasis that have not yet quite entered clinical practice, but I think you need to just be aware of it. Just pay attention right here. So this is an experiment in which insulin was introduced into the brain of mice, and what was looked at is the consequences of just exposing the brain, notably the hypothalamus, to low concentrations of insulin. What happens to the glucose production? So now what we're looking at is hepatic glucose production, output of glucose from the liver, which I just told you is suppressed by peripheral insulin action on the liver. And here you see that in these animals, insulin in the brain will cut the hepatic glucose production in half. This means that at least in rodents, there is a part of this pathway which is conveyed in the central nervous system. Insulin certainly gets into the brain, and some of what I just showed you here this suppression of hepatic glucose production could in fact be conveyed by effects in the brain. And suppression of hepatic glucose production is a critical therapeutic tool in the treatment of diabetes, and I would predict that in your early professional careers, you are going to see agents that are designed actually to have this effect or to convey this effect in humans as another way of suppressing hepatic glucose production, which is a major contributor to excess glucose in the circulation. So don't say you never heard about it, because it's right here. Another hormone that is said or believed to play a critical role in the derangements of glucose homeostasis in type 2 diabetes, and we'll come back to this right at the end, is this hormone glucagon, which is produced by the alpha cells of the islet and has effects in many ways which you can consider to be the inverse of what insulin does. So you squirt glucagon into the blood when your blood sugar gets too low. This is the emergency response to lowered blood glucose. It'll happen to patients if you inject them with too much insulin. Glucagon comes out and drives glucose production in the liver back up. So I showed it to you here, but I didn't say much about it. So here's the alpha cell. Glucagon release stimulates glucose production from the liver. This is an emergency response. But there's also evidence that dysregulation of glucagon plays a role in type 2 diabetes. So here are some mice in whom the glucagon receptor has been knocked out. And here you see the effect of beta cell destruction in normal mice. So normal mice having their beta cells ablated, and we have tricks for doing this, their blood sugar goes up, no big surprise. But if they can't receive a glucagon signal, in other words, if the glucagon that's in the circulation can't be sensed, their blood sugar doesn't go up. So a glucagon null mouse, despite having no beta cells, it seems to be quite happy with regard to its glucose concentration. Here's the insulin concentrations of these animals over time in response to a glucose load. And you can see that in the mice before having the knockout, the insulin goes up just fine. And here are the knockout mice after beta cell depletion or destruction. They're not making much insulin, as you would predict, but their glucose tolerance tests are normal. So how relevant this is to the human biology is a very hotly contested issue, but you're going to hear about it because people are going to develop pharmacologic agents to suppress glucagon production in service of actually trying to improve glucose homeostasis in humans. And these people here are two of the major proponents of this idea. So as an introduction to what I'm going to tell you next, which is about how obesity interacts with beta cells and insulin resistance, you need to just appreciate this. This is, again, no great insight. The fatter you are, the more free fatty acids you have in your blood. That's all that's being shown here. So you should know this. Fat people, obese individuals have higher levels of circulating free fatty acid than non-obese individuals. So the question is, what is the consequence of this? One of the reasons for it, obviously, is that they have more fat and that they're somewhat insulin resistant. Remember, insulin suppresses lipolysis, so the more fat you have, the higher your fatty acids. So it turns out that elevated fatty acids are not good for glucose homeostasis in two of the major organs that I've been talking to you about. So I'm not going to go into great detail about this, and you can read about it if you wish. But here, elevated free fatty acids, which cause increased diacylglycerol formation in muscle and thereby increase PKC, cause increases in serine and threonine phosphorylation of the insulin receptor. When you do this, this blocks the ability of the receptor to have tyrosine phosphorylation. All those phosphate groups that I showed you on the insulin receptor earlier are on tyrosine. So when you reduce tyrosine phosphorylation, you reduce PI3 kinase, and that in turn reduces glucose transporter 4 movement to the surface of the cell. So high levels of fatty acid, by virtue of effects of blocking insulin receptor action, reduce glucose transport into the cell. And this is the mechanism by virtue of effects on protein kinase C. In liver, very similar process, but here the decline in PI3 kinase reduces glycogen synthesis, which helps to keep glucose in the liver, and increases gluconeogenesis, which drives glucose out of the liver. So in the liver, what you get is increased export of glucose, and in muscle, reduced uptake of glucose. And this is a perfect storm for raising the blood sugar of an individual. So obese individuals, to some extent, are hyperglycemic as a result of the effects of fatty acid on these two major glucose metabolizing organs. Through protein kinase C, different isoforms of the molecule. That's why the epsilon is shown here. This is protein kinase C, I think, and this is epsilon. Again, result of reduced insulin receptor substrate phosphorylation. What other mechanisms are affecting insulin sensitivity? So this is actually a schematic from an experiment that was done by one of your classmates a while back, in which for the first time it was shown that in obese animals there are many more macrophages and other inflammatory cells than in non-obese animals. So this is a schematic of a lean mouse. This is a schematic of an obese mouse, which you probably can appreciate. And this is the adipose tissue of those two animals. And here these cells are surrounded by these macrophages. So when this discovery was made, we thought that the macrophages were bad, that they were doing something to impair glucose homeostasis, and there were various ideas about this, and I'm not going to go into the details. And that probably is still true to some extent, but time has led us to understand that these macrophages may be there for several reasons. One, to actually try to correct some of the metabolic disturbances that occur in obesity, to take up some of the extra fat, and that they're there not entirely in a negative way in terms of their effects on metabolism. And I'm not going to say any more about this, but you again are going to read in the literature evidence that if you suppress inflammation in individuals who are insulin resistant, and by doing so suppress the activity of cells like this, you can improve their glucose homeostasis. And the mechanism, the precise mechanisms by which this occurs, if I were you, I would be skeptical of, but the process is undoubtedly true. The observation is true. So I'm just sort of sensitizing you to something you're going to see. It's already there in the literature. So here to sort of encapsulate what I've told you so far, there are genes, aging and obesity, that affect muscle insulin resistance. You can throw the liver in there as well, increased fatty acids, and the beta cell now tries to compensate, as you'll see, by making more insulin. So type 2 diabetics raise their insulin to try to meet these stressors that are the result of the increased circulating fatty acids. This increases, as a result of the elevated fatty acids, gluconeogenesis in the liver. So there's more glucose output, less glucose uptake, shown here, hyperinsulinemia, impaired glucose tolerance test. This is the agate edge of becoming a diabetic. The beta cells give out functionally and probably numerically, and you end up with diabetes. So where you pick a patient up in this process is obviously critically important. And as you'll see, if you even pick it up as late as this, you can reverse the disease. I'll show you how. But it's much better, obviously, if we could get at this early on, particularly by getting at the problem of obesity. So just look at these two guys here. So here are rates of beta cell replication. Again, this is very schematic and based largely on a very small number of human studies, but in humans you have beta cell replication going on over at high rates early in life, and probably slow rates. You can see here, these are sort of arbitrary units throughout life and maybe tailing off with age. Type 2 diabetics have high rates, presumably, of cell replication early on, but their rates of replication fall off, again, probably for genetic reasons. And if they're insulin resistant or obese, this is enough in many of them to pitch them into the clinical phenotype. Now here is beta cell mass, which is a correlate actually of beta cell replication. So in normal non-obese individuals, beta cell mass may rise. I think this is probably inaccurate in attributing elevations as late as 50 or 60. It probably plateaus out much earlier. But in type 2 diabetes, beta cell mass declines. And when it gets too low, again, pitches the individual into a clinically apparent diabetic state. Oops, okay. So here is a famous study by Dr. Butler in which he's looking at fasting plasma glucose and beta cell volume. And all I want to show you here is that if you look at the mass of beta cells in individuals who are non-diabetic but obese, these are individuals at risk of becoming obese, they actually have more beta cell mass than a lean non-diabetic individual. In other words, they're trying in a teleologic sense and certainly in a physiologic sense to overcome the consequences of their insulin resistance. But as they become impaired, this is impaired fasting glucose, and ultimately develop type 2 diabetes, the beta cell mass declines. And it's the combination of the decline in beta cell mass and increasing insulin resistance that leads to the overt disease. But to start with, they actually, many of them have an appropriate sort of compensatory increase, which I showed you in that earlier schematic. So again, for purposes of making sure that you appreciate the sort of various thoughts about the pathogenesis or etiology of type 2 diabetes, one of the things that's now quite popular is the idea that if you are exposed in utero to a dysmetabolic environment because your mother is either insulin resistant or obese or both, this may affect you in terms of the development of your beta cells and brain and other organs so that you end up like this 25 years later. In other words, you can blame it on your mother's obesity or her dysmetabolism. So what's the evidence for this? And again, this comes primarily from American Indians. So here what we're looking at is women, the prevalence of diabetes, the percentage of diabetes, and the offspring of women who ultimately developed diabetes but were in various states, either non-diabetic, pre-diabetic, or diabetic at the time that they gestated their baby. So this controls for the fact that there's increased susceptibility genetically conveyed in diabetic individuals. So here what you're looking at is the age of the children and the percentage of them who are overtly diabetic by that age. So if your mother, and you're a Pima Indian, was diabetic during her pregnancy, you have a 20% chance by the time you're 15 to 19 of having the disease. And it goes up, obviously, as you get older. So by the time you're 25 to 29, there's an 80% chance you've got the disease. But even if she was non-diabetic or pre-diabetic at that time, you can see that there is additional risk that is conveyed, presumably by her dysmetabolic state, even before she became overtly diabetic. Another way of looking at data like these, again from the Pima Indians, is to look at individuals in terms of their acute insulin response, which is the AIR, and their ability to dispose or move glucose into peripheral tissues. So high is good, low is bad. High in terms of insulin production in this case would be good, low would be bad. And if you take individuals and look at them anticipatorily, in other words, before they become diabetic, the individuals who are ultimately become diabetic, the majority of them, or a large percentage of them, come from individuals who already have derangements in disposition of glucose and in the acute insulin response. In a sense, this is no great news, but it basically shows you that the predisposition to become diabetic is conveyed by a combination of insulin resistance and dysregulation in terms of the beta cell's capacity to produce insulin. And another way of looking at this is what I like to call this sort of like a Starling's curve, which you've probably seen with regard to the cardiovascular function. So here, as insulin sensitivity declines, if insulin release increases, glucose homeostasis will stay normal. But as these components fail, for example, as the insulin release becomes insufficient for the reduction in insulin sensitivity, which is in turn conveyed by obesity, you get impaired glucose tolerance, and then ultimately, when the sufficiency of insulin production becomes too low, you develop overt disease. So this is sort of the natural history of what I just showed you in that earlier slide. Some individuals actually are able to fully compensate. Those who don't drift this way towards the development of diabetes. So I've said it a bunch of times, but I'll now show you just briefly a little bit of data about the relationship of obesity to the risk of diabetes. I like to point out to the students that here, in terms of catastrophes of war, the reductions in the rates of obesity in those individuals living in these areas cause striking reductions in diabetes. So, for example, the Germans have helped the French on at least 3 occasions by invading their country, starving out the population to various extents, and certainly reducing the prevalence of diabetes. In Paris, in all 3 of these wars, the prevalence of diabetes and its incidence dropped extraordinarily because they were being starved to death, basically. On the other hand, if you take individuals from these cultures or countries and move them to environments in which it's easier to become obese, the prevalence of diabetes goes in the other direction. So Japanese migrating to Hawaii, Indians moving to the UK, etc., these individuals become fatter and more diabetic within a single generation. Weight loss, as I've said repeatedly, or at least implied repeatedly, will either prevent or ameliorate this. So here is an old study. You don't need a lot of these to get the point. These are glucose tolerance studies in individuals who are, and this is plasma glucose and plasma insulin. So here are individuals who are diabetic. Here are these are 2 groups of diabetics, and these are the normal controls. So here are the individuals when they were obese, and here they are after they've been on a diet, not specified in this case, but have had some weight reduction. So you can see their glucose tolerance is improved tremendously. And here you can see the serum insulin of normal weight individuals, and here are the individuals before and after weight reduction. You see that their serum insulin release is suppressed, as I have told you before, but that if they lose weight, that this insulin is sufficient to actually mitigate, not fully correct, their blood glucose concentration. So weight loss is good. Prevention of weight gain is even better. So here is an example of prevention of weight gain. This was an extraordinary study done through the NIH, the DPPT, this is Diabetes Prevention Trial, tremendously expensive, major intervention in individuals who had impaired glucose tolerance. So they're in that yellow zone of the glucose and insulin homeostasis that I showed you before. The group that had intervention, which was major lifestyle changes and increased rates of exercise, this is the proportion who ultimately developed diabetes over a period of 6 years. So you can see that, whatever this works out to, about 15% of the individuals who had the major intervention. In the control group, who got sort of mild advice and jawboning about what to do about their obesity, 40% of those went on to develop diabetes. So you can prevent this disease by very, very aggressive attention to lifestyle and body weight. It's just very hard for people to do that. Here's another example of this, even more striking. So as many of you know, you can ban the stomach, and this will prevent food intake in individuals and produce weight loss. Not as striking as you get from a full so-called bypass surgery, but this works to a lesser extent and doesn't affect the metabolism of the gut, which is why this experiment is interesting. So here, these are individuals who started at a BMI of 30 to 40, so already very obese, and some had the surgery, had a band, and others were treated by conventional means. So these are people who are BMI 30 to 40 and had type 2 diabetes of relatively early onset. So here you can see in the conventionally treated group, the weight loss was minimal, and the number who reverted their diabetes, 3 out of this total group actually had a remission of their diabetes. Whereas the group that had a 20% reduction in body weight as a result of the surgery, the majority of them, their diabetes went away, meaning they were off all medications and were free of the phenotype. So what does this mean? It means that if you get to the disease early and reduce body weight, unfortunately diet alone is not particularly effective, you can reverse the disease. You can relieve the beta cells of the stress that's causing the diabetic phenotype. This is a very interesting observation, obviously, because it tells us not only can you prevent the disease if you treat it aggressively, but you can revert it if you get to it early enough. How long this regression would be durable remains to be seen. So here is something about the genetics. Remember, I told you that the genetics of type 2 diabetes is largely beta cells, and I'm not going to go through this in great detail. You can look at it yourself, but this is a map of the human chromosomes, and you can see marked on here for your edification are genes, common GWAS, genome-wide association genes, that have been implicated in human type 2 diabetes. There are many of them, and virtually all of them are beta cell genes. And the MODY genes that I alluded to earlier are shown on here as well. So here's the good news is we know about a lot of the genes, or at least some of the genes, but look at what happens when we try to see their contribution to elevated blood sugar. Remember, fasting plasma glucose as an indicator of diabetes. So here what's being looked at is the number of high fasting plasma glucose alleles based on a map like this. So here's the map. You take some of the alleles, you start now adding them up. This individual has 3, This one 4, this group of individuals 4, 5, 6 to 8. So if you go from 0 to 6 to 8 risk alleles, you're only talking about 0.3 of a millimole per liter of glucose. In other words, you get the expected relationship, but we can't account for the vast majority of the risk variance. So we know a lot about a lot of genes, but we're still not accounting for the majority of the risk. This is a highly statistically significant finding here, 10 to the minus 33, that's right up there. But we're not accounting for a lot of the phenotype. So the current thinking about this is there may be rarer alleles of these same genes. This GWAS is biased towards alleles that have at least a 5% frequency. There may be rarer alleles with bigger effects that are accounting for this, or we may have missed some of the genes by doing the GWAS studies. And there are a variety of strategies underway to try to figure this out. But currently, the genetics cannot account for the majority of the risk. So again, to just summarize the genetics a little bit more for you, here are a series of genes that I alluded to that are primarily in the brain. There are many more. There are probably 50 of them that lead to obesity and insulin resistance. And that insulin resistance acting on susceptible beta cells. Here are some of the genes that have to do with susceptibility. They're on that map that I showed you. Here, the obesity risk of the obesity conveys insulin resistance. So now the normal beta cells are under stress, and ultimately, if you have a normal beta cell, you will compensate. You'll make more beta cells, and you'll make enough to compensate, like on that Starling's curve. You'll be okay. They'll be stressed, but you'll be all right. If you have genetic predisposition which does not tolerate the increased insulin resistance, you get beta cell dysfunction, impaired glucose tolerance, and then type 2 diabetes. But remember, I showed you, even in individuals who are susceptible, if you prevent the obesity, you can prevent this phenotype, and even if it occurs, if you roll the obesity back, you can roll the phenotype back. So strong genetic predisposition, but the environment is dispositive, actually, with regard to whether you ultimately, or at least in many instances, develop the disease. So again, thinking about this sort of gene by environment interaction, there are genes that have severe effects on insulin homeostasis. This is permanent neonatal diabetes mellitus. I didn't talk to you about this, but mutations of these genes, or all beta cell genes, can lead to essentially neonatal onset of diabetes. There, the genetics is essentially dispositive. Those MODY genes are sort of intermediate in terms of genetics. And then these other genes that convey more modest effects have less of a primary genetic effect and are interacting strongly with the environment. So the point is that the majority of the diabetes you're going to see is going to be out here, where there's genetic predisposition, but the environment, meaning obesity in this case, is really driving these individuals towards becoming diabetic. So the higher the genetic loading, the earlier the onset, and the slenderer the individual is likely to be. These babies are not obese. The lower the genetic loading, the later the onset, and the more obese the individuals will be. And by genetic loading, I mean the penetrance of a given gene with regard to the development of the disease. So I'm going to end by just talking to you about sort of the latest and greatest in terms of other ways of approaching this disease other than preventing it, obviously, which is the best. So we and others have learned how to use stem cells to make beta cells. And these beta cells ultimately can be used to study the physiology of the disease and the contribution of some of the genes that I just talked to you about, and ultimately perhaps be used to put into human beings to replace the beta cells that have been lost by one mechanism or another. Other strategies involve reprogramming other cells. And in a slide or two from now, I'll show you alpha cells are these glucagon-producing cells. These are the cells, the acinar cells are the cells of the other parts of the pancreas, the enzyme-producing parts, and even reprogramming hepatocytes into beta cells. So there are two major strategies. One is to use stem cells to make a beta cell. The other is to try to reprogram other cells in the body to become beta cells. Added to this should be gut cells, which we've actually been able, Mimo Achille in our group, to do, to reprogram a gut cell to make insulin. So we can take these iPS stem cells and make beta-like cells. And again, obviously, I'm not going to give you the details of this, but trust me, this can be done. We could take the skin cells of any one of you in this room and make a beta cell from it. And ultimately, I think, certainly use those to study the disease, but ultimately maybe to transplant. So here's an experiment that we did in which we took beta cells from individuals who have a form of MODY, which is glucokinase mutation. And what we're looking here is the response of a mouse that's been transplanted with those cells in terms of its ability to produce insulin after a glucose challenge. So we can measure the human insulin in the bloodstream of the mouse because it's different enough from the mouse insulin to be immunologically detectable. And so we've actually transplanted insulin-producing cells that either have the MODY mutation, which reduces the insulin release. We've here even made the mutation more severe, but more importantly, here we've corrected the mutation using, again, some molecular genetic tricks and have returned it to normal function, essentially. So the details here are not critical, but I want you to appreciate that it's now possible to take human skin from individuals who have diabetes, make insulin-producing cells after the mutation has been corrected. So you don't need a big imagination to understand what this might mean for the treatment of diabetes, and not just type 2 diabetes, obviously, but type 1 diabetes as well. We can make beta cells, we can correct the mutation, and the function is restored. So I'm going to end on this slide, which is sort of the latest thinking about this redifferentiation idea. So what I just showed you is making new beta cells, but here is the sort of view of what happens to beta cells that are in an environment of insulin resistance. So here's normal beta cell. Here's a beta cell that's struggling because it's beating up against this insulin-resistant environment. And remember, I showed you, you actually, when you do that, you actually get bigger beta cells or more of them, and they produce more insulin. But ultimately, these cells fail. And the conventional view of this is they get dysfunctional, they start to produce less insulin, they're a little crapped out, and then they're dead. The newer view of this is no, they're not dead. What's happened is that they have de-differentiated. They have gone to a more early stage of development. They've regressed, if you will, and the neurogenin 3 is a molecular marker of this, so that they're not dead. They're producing less insulin, and then they de-differentiate into other cell types. And here, one of the cell types they de-differentiate into, in this case, is a glucagon-producing cell. And I went through this big deal for you about how glucagon production is believed by some to be a major or important mechanism for derangement of glucose homeostasis in diabetes. So you can imagine that a type 2 diabetic with failing insulin production who now is producing more glucagon, this is a bad situation. So it may turn out that trying to do something about this excess glucagon production will be helpful therapeutically, but even more promising would be to try to reverse this process by some molecular tools. We know a lot about the molecular basis for the de-differentiation, and the idea would be there's still cells in the pancreas, in the islets that are salvageable in this sense, and we may not have to make new ones. All we would have to do is rescue the sick ones so that they go back to being healthy beta cells, which would obviously remediate the disease. And these are things that you're undoubtedly going to deal with as clinicians or in research. So now you know. Thank you. Now we have the airing of grievances. Does anyone have any, do you all know what the airing of grievances is? Festivus, right, on the Seinfeld? No, you don't know about that? Oh, my God. All right, well, one of your assignments, as soon as we're done here, look on YouTube for Festivus, which is the replacement for Christmas in the Seinfeld show, which involves, among other things, the airing of grievances. There's a pole rather than a tree. Anyone have any? No, okay. Yeah. But you know about Festivus? No. Oh, my God. What is the matter with you?
I don't want to be my question was about,
I guess that's all right.
my question was about this hypothesis that you shared in the discussion that you talked about that you love in every state that happens. And I'm wondering, I'm trying not to be pathogens.
Yes.
In some ways, you could posit are you genetically predisposed to having dysfunctional baby cells, or maybe you might have some kind of in type 1, right? And maybe you're likely to
Yeah.
this
She'll come in. I think this is the one, but she'll. Oh, okay, good, good. We're kind of on yesterday, too.
Yeah. Yeah.
So,
Yeah, you can do it.
yeah, the first one.
The second one, I think, but yeah.
Oh, okay. So,
Yeah. It seemed like there was a connection story there, right? Where all of a sudden there's this inflammatory.
thank you.
Do you want to pull it onto the desktop so that you don't forget this later? Oh, yeah, thank you.
And remind me this thing. Yeah, do you move around a lot? No.
Because you could just use this one,
Yes.
or you could. I usually just stand here, but some people move.
No. Almost done. For you. this, right?
Yeah, or you can use, and then that advances also.
And this works.
Yeah. But this is also works,
Yeah.
whichever one is.
Yeah. Hello. Right. So then, oops. Hi. So let's get started. Hello. We're going to talk about the acute and chronic complications of diabetes today. So we can get ready for you guys to go to the small groups soon. This doesn't work. Okay. All right. The plans? Yeah. Okay. I have no conflict of interest, and you can read the teaching objectives. So we are starting with the acute complications of diabetes, and you had learned already some of it, namely the hyperglycemic hyperosmolar state and diabetic ketoacidosis. These are metabolic changes that occur with diabetes. Traditionally, or in general, hyperglycemic hyperosmolar state is seen in patients with type 2 diabetes and diabetic ketoacidosis in patients with type 1 diabetes. But there is an overlap, and 30% of patients with type 1 may become hyperosmolar, and some patients with type 2 diabetes may present with diabetic ketoacidosis. Hyperglycemic hyperosmolar state is characterized by a marked hyperglycemic state, usually blood sugars over 600 or 800, associated with dehydration and increased osmolarity. In diabetic ketoacidosis, the hallmark of it is the presence of ketones and resulting in metabolic acidosis. The dogma has been that patients who have this marked hyperglycemia, who are on HHS, patients with type 2 that develop hyperglycemic hyperosmolar state, do not go into diabetic ketoacidosis because they have insulin that prevents the ketosis to occur, albeit low, very low levels, but enough to prevent ketosis from occurring. Not enough to prevent the hyperglycemia, but yes, the ketoacidosis. In order to develop DKA or diabetic ketoacidosis, you have to have two factors. You have to have lack of insulin or very, very low levels of insulin, usually undetectable at the time that you measure in the acute event, and you have to have an increased level of counter-regulatory hormones, particularly glucagon. These increased levels of hormones may occur because you have an infection or a particular stress event that increase the levels of these hormones. What they do is they increase or they stimulate the production of ketones, and ketoacidosis occurs. So insulin, lack of insulin will allow this process to occur, will allow ketosis to proceed, but the counter-regulatory hormones, particularly glucagon, is the one that directly stimulates ketogenesis. There is usually a precipitating factor. Most of the times will be an infection, pneumonia, UTI in about up to 50% of the patients, but other events can precipitate DKA, particularly pancreatitis or inflammation of the exocrine pancreas, a heart attack, a stroke, certain drugs, glucocorticoids, particularly the atypical antipsychotic medications, cocaine. There is no obvious cause of precipitating cause in up to 10% of the patient. However, I want to point out that insulin omission can occur in about a third to a half of the patients. This is particularly true in patients who have psychiatric diseases, conditions concomitant with diabetes, or patients who have socioeconomical factors that impair their ability to obtain insulin, or sometimes rebellious teenagers who omit the insulin. And it's not just one day, but usually at least 24 to 48 hours of lack of insulin can predispose to diabetic ketoacidosis. The triad, characteristic triad in DKA will be hyperglycemia, and this will be directly because of lack of insulin, and ketonemia, or ketones in the blood that lead to metabolic acidosis. And this is due to the stimulation by the contrarregulatory hormones, which is allowed to happen because of lack of insulin. The ketones, there are three main ketones, the 3-beta-hydroxybutyrate, the acetoacetate, and acetone. They are derived from the fatty acids, lipolysis, and acetyl-CoA. 3-beta-hydroxybutyrate converts into acetoacetate by reduction of the hydroxyl, and this metabolite can be measured in the urine by the ketone sticks and is eliminated through the urine. Acetoacetate can be converted into acetone, which is a ketone, but is not an acid, therefore not responsible for the diabetic ketoacidosis state. The acetone can be eliminated through the respiratory system and may be responsible for that fruity smell that you may read about that you can see in patients with DKA. The clinical presentation, well, the hallmark of diabetic ketoacidosis in terms of symptoms is nausea, vomiting, and abdominal pain. The other symptoms we're going to talk about are related to the hyperglycemic state or dehydration, and can be seen on hyperosmolar state or just marked hyperglycemia without any other abnormality. However, the hallmark for diabetic ketoacidosis, particularly when it's severe, is nausea, vomiting, and abdominal pain. You can see, as a consequence of hyperglycemia, polyuria, because after the sugar reaches certain level, over 180 milligrams per deciliter, will be lost in the urine, and it won't be reabsorbed. And the sugar likes to go, exerts osmotic pressure, so sugar and water is eliminated, and that's why you have increased urination. In order to compensate for the loss of liquid, the loss of volume, increased thirst occurs, and you drink more. However, if you don't drink enough, and usually that happens, dehydration occurs, and consequent with dizziness, palpitation, hypotension. Blurred vision occurs because there is a swelling of the lens from the glucose that gets into the lens, and associated with edema because of the osmotic pressure. This resolves, but can take weeks to resolve once the sugar is normalized. And the hyperosmolarity will occur because of increased sugar and dehydration. There is an effort of the body to compensate for the metabolic acidosis by breathing deep and slow breaths, and that's the Kussmaul respiration, to get rid of the CO2 and trying to compensate with causing a respiratory alkalosis. We talk about the fruity breath, the dehydration that occurs because of the polyuria, and consequent hemodynamically and instability because of the dehydration can cause tachycardia to compensate for the volume loss, and hypotension. Mental status changes can occur when the decay is severe, or in particular in hyperosmolar states in elderly patients. What are the blood tests that can help with the diagnosis of DKA. Well, you're going to have an increased sugar, usually over 200 milligrams, 250 milligrams per deciliter. By definition, you are in acidosis, so the pH will be lower, usually lower than 7.3. And the bicarb will be low because it's lost in the urine. There is an anion gap acidosis, and you've probably already done this in the renal diseases, and that is the ketones causing the anion gap. And that's why it's important to measure the ketones in the urine or in the blood, because there are other states associated with anion gap metabolic acidosis that are not DKA. For example, alcoholic ketoacidosis, which sometimes can be associated with a slight hyperglycemia. So it's important to measure the production, the metabolic results of this disease, which is the ketonuria or the ketonemia. Lactic acidosis will be another disease associated with GAP metabolic acidosis, which you need to differentiate. Doesn't mean that a patient who has diabetes couldn't have lactic acidosis, not automatically DKA. And to differentiate both conditions, this is a table that shows you the different measurements, but just to point out the hyperosmolar state, I think. All right, well, you see on the right the hyperosmolar state. The sugar is usually over 600 milligrams per deciliter. Many times it's 1,000 or over 1,000 milligrams per deciliter, as opposed to diabetic ketoacidosis, where the sugars are elevated, but moderately so. Why is that? Well, it's possible that usually hyperosmolar states occur in older individuals. They may have some degree of renal insufficiency, and they're unable to rid themselves from sugar through the urine, and that's why the sugar accumulates in the blood and reaches these higher levels. In addition, these patients may be elderly and unable to obtain water when they're thirsty, and their sugars continue to go up, as opposed to patients who are usually younger, type 1 diabetes patients who are usually younger and able to respond to the increased thirst. And you can see by definition, the pH will be normal in hyperosmolar state and low in DKA. The serum bicarb similarly will be normal in hypersmolar state and low in DKA. And particularly the serum osmolarity will be much higher because of the increased glucose and the marked dehydration that occurs in hypersmolar state, with a water deficit that may be 9 liters or more in this condition, as opposed to DKA, which is lower. And the goals of treatment are first to replace the fluids, usually with IV fluids, normal saline or half normal saline, but there is we need to correct the fluid deficit in both hyperosmolar state and DKA. And that per se will lower some the sugar, and in hyperosmolar state even more. But the correction of ketosis and acidosis will only be achieved with the administration of insulin. Usually IV insulin by different protocols available, but occasionally you can use IM and subcutaneous forms of insulin administration. But only insulin will correct the ketosis and acidosis. And both the fluid correction and the IV or sub-Q administration of insulin will correct the hyperglycemia. Hyperglycemia may be corrected within 6 to 8 hours. However, you may need to continue insulin administration in order to correct the ketoacidosis that may take up to 24 hours to correct. In fact, many times you have to add dextrose once you corrected the sugar in order to allow high doses of insulin to be given. You replace the electrolytes that are lost in the urine, particularly the potassium and phosphate sometimes, in order to avoid the arrhythmias that can occur when potassium levels go very low. And you try to determine if there was a trigger, if there is an infection, you are going to treat appropriately. So we're going to switch gears to the chronic complications of diabetes. These are the ones that will cause the morbidity, the majority of the morbidity and mortality associated with diabetes. We can classify the complications into the microvascular and macrovascular complications. The one on the left are the microvascular complications, or diseases of the small blood vessels that affect the eyes, the kidneys, the nerves. The cardiovascular disease, strokes, heart attacks, diseases of the macrovascular tissues. And why are these tissues, the kidneys, the eyes, the nerves, why are those cells and tissues more affected than others? We are not sure why. I mean, comparing to liver or muscle, why are these cells are particularly harmed in diabetes? And we don't know, but it's possible that these cells cannot defend themselves against the ambient hyperglycemia, as well as other cells that may not allow the entrance of sugar as easily as these particular cells. But there are other theories of why these cells are affected and no others. But also, it's important for you to know that although the pathogenesis of type 1 diabetes differ from that of type 2 diabetes, in terms of the complications, the pathogenesis of the complications of both conditions seem to be similar. And both are affected by similar complications and degree of complication. So we know that hyperglycemia directly affects or causes diabetic tissue damage in the kidneys, as we talk, or in the nerves, or in the eyes. And this is through changes in the metabolic cellular metabolisms and long-term changes in macromolecules. So hyperglycemia is the main factor related to diabetic tissue damage. However, there are other determinants, individual susceptibility factors, particularly genetic factors, that can modulate the degree of the complications for more or less. There is a study, ongoing study by the Jolson Diabetes Center for individuals who have diabetes for over 50 years, and they have very little or no microvascular complications. And they're trying to ascertain what are the factors that allow these patients, which many of them didn't have good blood sugar control, particularly in the, if they have diabetes for 50 years, you can imagine that the more modern ways to treat diabetes, they were not available to them 20, 30 years ago. So particularly initially, they did not have good blood sugar control. However, they have very little complications. This is are an unusual group of patients. It's the minority, but they may have certain genetic determinants that help them prevent their degree of complications. Similarly, there are independent risk factors that can make or accelerate the degree of complications, particularly hypertension for diabetic nephropathy. If you treat hypertension in diabetic nephropathy with similar degree of hyperglycemia, the complication is decreased. So hypertension is a risk factor for diabetic nephropathy. Similarly, pregnancy can accelerate the degree of retinopathy on patients with type 1 diabetes. And that's why we follow these patients very closely during pregnancy in order to avoid this worsening of their retinopathy during that short period of time while they are pregnant. So again, we know that hyperglycemia causes tissue damage, but what are the fine mechanisms responsible for this tissue damage. And there are many theories, and I'm going to talk about only 4 of them. There are more in order of appearance. This is the activation of the polyol pathways being described in the 60s, the glycation theory with advanced glycation end products that started in the 70s, but actually still ongoing as a theory for why there occurs tissue damage with chronic hyperglycemia, the protein kinase C activation, increased exosamine pathways. And these are not mutually exclusive mechanisms. They may be a combination of them and even others that I'm not describing that lead to tissue damage in chronic hyperglycemia of diabetes. So the first one, the polyol pathway, normally the aldose reductase is an enzyme that is in charge of getting rid of toxic aldehydes and inactivating to alcohols. But when there is hyperglycemia in the cell, aldose reductase levels are increased, and they convert the glucose to sorbitol and eventually to fructose. In that process, the aldose reductase utilizes NADPH for its activity, rendering the levels of NADPH lower and decreasing the activity of certain enzymes, particularly, for example, the glutathione reductase that needs NADPH to reduce the oxidized glutathione. And this causes an increase of oxidative products and oxidative stress that can lead to inflammation and chronically changes in the cells. Another theory that you will hear a lot about is the advanced glycosylation end products and the formation of these products during chronic hyperglycemia, leading to tissue damage. The microvascular disease is thought as an accelerated process of aging. These advanced glycosylation end products occurs in normal aging, not just in diabetes, where the amino terminal of proteins and sometimes the nucleic acid bases or certain lipids are covalently linked to glucose, non-enzymatically so. Just with time, the glucose links to these products and causes this intermediate products called the Amadori product and intermediate glycosylation products that then they are irreversibly going into the so-called advanced glycosylation products. And what's the problem with this products? Well, the ages can damage cells by different mechanisms. I'm going to mention 3 of them. The precursors the age precursors can affect the transcription factors and increase or decrease the stimulation, the production of certain proteins. In addition, these age products can go into the cell membrane, can diffuse to the cell membrane and bind to the matrix, bind to collagen, and create abnormal cell membrane proteins, which may make them more easily that could be broken or leak from them. They can also go into the plasma and go and bind the H receptors on certain inflammatory cells and increase the production of growth factors, cytokines, and inflammatory mediators that can do harm to cells. Another way by which hyperglycemia can cause tissue damage is the activation of protein kinase C, and it will depend on the tissue we are talking about. Hyperglycemia can increase the DAG, acetylglycerate, and increase the protein kinase C, the beta and the gamma isoforms. And it depends, again, on the tissue we are talking about. It can increase the it can decrease the eNOS, nitrous oxide, and that will result into blood flow abnormalities. It can increase the VEGF, which is a vascular endothelial growth factor and will increase angiogenesis. It's particularly important in the retina and the eye disease. And it will increase, in general, capillary occlusion, vascular occlusion, ischemia, and inflammation. Another mechanism describes the increased exosamine pathway, which when there is hyperglycemia, the glucose, the glycolytic pathway may be saturated. Glucose gets converted into glucosamine 6-phosphate, and then products of that will be incorporated into transcription factors and stimulate the production of inflammatory factors. So just to summarize, we describe that hyperglycemia may lead to microvascular complications, and that is observed in both type of diabetes, type 1 and type 2. We describe that some tissues are particularly susceptible to damage by hyperglycemia, particularly the kidneys, the retina, the endothelial cells of the retina, and the neurons of the peripheral nerves. And we describe 4 mechanisms by which hyperglycemia may cause this tissue damage, and these mechanisms are not exclusive, mutually exclusive, and there may be more than those 4 described. So now we go to the specific complications. Retinopathy affects the capillary endothelial cells of the retina. It is the most common complication in diabetes, and it is the most common cause of blindness in the industrialized world in middle-aged individuals. The 20-year prevalence of diabetic retinopathy is almost 90% in patients with diabetes. And we can classify the retinopathy into the non-proliferative or background retinopathy, which had different degrees of severity, proliferative or neovascular condition, and macular edema. Not because you have a mild background retinopathy, you will end up having proliferative retinopathy. Only 15% of patients who have mild non-proliferative retinopathy will progress into the proliferative or severe disease. However, if you do have severe non-proliferative retinopathy, the chances to advance into the proliferative state is about 60%. And the proliferative retinopathy and macular edema are the ones that may result in blindness. So what are the characteristics of the non-proliferative retinopathy? There is a decrease in the retinal blood flow, resulting in ischemia, increased vascular permeability, resulting in edema in certain areas of the retina, microaneurysm or small pouches of the small retinal blood vessels. You can have intraretinal hemorrhages. You can have, and that's because of the leakage that occurs from those blood vessels. And when there is leakage, the products, whatever is inside the blood will pour into the back of the retina, and when it gets the water, the fluid gets reabsorbed, hard exudates will remain, particularly lipids and proteins. This is as if there is a river that floods, and then when the water gets reabsorbed, the detritus or the debris will remain as the dirt, and those are the hard exudates. As opposed to soft exudates, that is a characteristic of more of a proliferative retinopathy secondary to ischemia. And this state is asymptomatic. That's why it's very important that patients have an yearly eye exam to find out that they already have this type of retinopathy in order to follow them more closely. This is an example of a fundoscopic exam on a patient with non-proliferative diabetic retinopathy, and you can see the hard exudate, those deposits of lipids that occur after extravasation of blood occurs, and they remain in the back of the retina. They are harmless in general. You can see an example of a hemorrhage there. And of course, the blood vessels and the optic disc that appear normal. But the scary phase is the proliferative diabetic retinopathy phase. By definition, this is a neovascularization phase or the new vessel formation. When the ischemia in the retina is extensive, there is a stimulation of VEGF, or vascular endothelial growth factors, that in turn will stimulate the growth of new vessels on the retina, on the posterior surface of the vitreous. The intention is good because you're trying to, if you have not enough blood going through the retina, through the normal blood vessels, well, your response will be to make more vessels to avoid ischemia and irrigate the parts of the retina that are ischemic. However, these new vessels are fragile. They are poor quality, and they commonly leak, and they lead to major retinal and vitreous hemorrhages that are the cause of the blindness in patients with diabetes. So you see here, again, a fundoscopic exam of somebody who has proliferative diabetic retinopathy, and you see an example of those curly, irregular-looking blood vessels. Those are the new vessels or neovascularization, and you can compare with the smooth vessels that you can see in the background. And those can break, leak, and cause major hemorrhages. And here you have an example of somebody who have new vessels. You can see in the background those kind of curly-looking blood vessels, sometimes thicker. And you can see the bleed, pre-retinal and vitreous hemorrhages that are significant. This is not microhemorrhages, they're major hemorrhages. And what happens is when the clot forms, eventually it contracts and forms a scar tissue and fibrous tissue, which with it brings the retina out and causes complete retinal detachment. This is complete blindness when you get to this stage. So what you have to do is avoid to get to this stage, obviously. Here is the incidence of retinopathy in patients with diabetes, and I mentioned initially that you can get up to 80 or 90% of diabetic retinopathy in patients after 20 years or so, but this is the so-called the background on non-proliferative diabetic retinopathy. You can see that it takes about 5 to 10 years to start having an impact, and then about 10 to 15 years when you see about 80% of patients with this condition. However, the proliferative disease takes longer to occur. It doesn't occur until at least 10 to 15 years. And it can reach an incidence of about 60%. But this, as you see, they're older cohorts born in the 40s, 50s, 60s, and 30s. If you were to do, not shown here, a curve with the newer cohorts, maybe born in the 70s, 80s, 90s, the curve would be much lower, but at least 50%, because of the newer developments and newer treatments of diabetes. Because, I will mention again, it is hyperglycemia that causes this complication. And it's type 1 and type 2. You see this situation in both conditions. In this particular study, type 1 diabetes had a higher incidence, but it's just because of the studies. Both type 1 and type 2 can result in diabetic retinopathy. And the blindness results from the hemorrhage of the vitreous and traction of the retinal and retinal detachment. Macular edema, which is the area of the eye that has the higher concentration of vision, can also lead to visual problems. And increased intraocular pressure due to this new vessel formation and bleed can also lead to blindness. The 5-year risk is about 60% for proliferative diabetic retinopathy, resulting in visual loss. The risk, as we mentioned, the poor metabolic control is the paramount risk for diabetic retinopathy, but increases with duration of diabetes. And we talked about pregnancy being an accelerator of diabetic retinopathy. Laser is the treatment for advanced proliferative diabetic retinopathy. It's a pan-retinal photocoagulation. You can do focal photocoagulation for macular edema, and inhibitors of the VEGF, intravitreally administered injections, is used for macular edema. What laser treatment does is slow the progression of retinopathy. It does not restore vision, but reduce the potential visual loss by about 50%. How does it do that? Well, this is an example of the little laser dots. Each one of these yellow circles is a laser dot, and you can see that it's aimed to the peripheral of the retina, trying to leave the macula alone. And what it does, it actually burns retina. Every dot is retina that has been burned, therefore not functioning anymore. But what happens is when you decrease the retinal tissue, you decrease the metabolic needs of the retina, and therefore decreases the VEGF formation and the new vessel formation. You also decrease vision in the periphery, and patients have visual difficulties at night, but at least they have preservation of the macula and the area where there is most of the vision. So we're going to switch to neuropathy, and the overall prevalence of neuropathy is about 30%, but it does increase with age. By the time you have 25 years of diabetes, it's about 50%, and this shows the same, that duration of diabetes increases the incidence of the prevalence of neuropathy, and similarly, the older the patient, the higher the incidence or the prevalence of neuropathy. There are different clinical syndromes associated with neuropathy, the most common one being the polyneuropathies, the distal symmetric polyneuropathies. But it can affect the autonomic system, the nerve roots coming out of the spine, thoracic and lumbar, and can affect single nerves. For example, third nerve palsy is relatively common, or limb palsy like radial palsy. But polyneuropathy, we're going to talk about the rest of the little talk on neuropathy, is the most common one. It affects up to 50% of the patient and is predominantly sensory, not motor neuropathy. It's distal, it affects the lower legs, it's symmetrical, and that's why it's called stocking distribution. Also glab, although it's rare to see in upper extremities, but it could be seen. It affects both large or small fibers. I mentioned it's mostly sensory, and it can be characterized by negative symptoms and positive symptoms. The positive symptoms meaning pain, burning pain, that's called dysesthesias, or the feeling of pins and needles, that's called paresthesias. Or you can have negative symptoms, for example, numbness or difficulty to sense hot temperature. This sensory loss, particularly the numbness, in coupled by the peripheral vascular disease, is the major cause for amputation and limb loss, because you don't feel, for example, you're walking, you don't feel little things in a new shoe that is rubbing against your feet, and if you would have normal sensory, you would have stop, change your shoes, accommodate, put socks. Patients who have numbness do not feel, and by the time they look at their feet, it's already a small ulcer that can progress if they are coupled again with macrovascular disease, or decreased blood flow in the area. It's hard to heal and eventually can lead to the loss of a limb. And here's an example of severe neuropathy and a characteristic ulcer of neuropathy, which is in the back of the foot as opposed to being on the toes. That would be more of a vascular ulcer. And you can have lack of sensory from the large fibers, and that can be seen as a loss of vibration sense and proprioception that can lead to Charcot foot, which in this case, in addition to the ulcer, you can see the deformity of the foot is an arthropathy that occurs due to the lack of proprioception. You can measure the vibration sense with monofilament in different areas, and not the vibration sense, the sensory, and you can measure the vibration sense with a tuning fork. Autonomic neuropathy is less common, but devastating complication of diabetes, and it can affect both sympathetic and parasympathetic system. And it can affect many of the organs that are innervated by both the sympathetic and the parasympathetic system. Particularly in the cardiovascular disease, can cause, if it's affected by the if it's affecting the parasympathetic tone, you can see tachycardia or increased heart rate. When the neuropathy advances, you can see both innervation of the parasympathetic and sympathetic, and you can have a fixed heart rate, usually in the 90s. It is associated with increased mortality, usually due to arrhythmias. You can have silent ischemia and postural hypotension, which is the inability to raise your blood pressure when you are standing because of the difficulty with the sympathetic response. In the GI system, gastrointestinal system, gastroparesis is not very uncommon actually to see, and it's the difficulty of the gastric emptying after eating. These patients, instead of normally emptying their stomach in an hour or two, take hours to do so, and they have nausea, vomiting, and feeling of satiation. Diarrhea is less common, but but it does happen, and it's usually nocturnal. Constipation is much less common to occur when you have autonomic neuropathy. So, going a little fast here, but we're going to go into nephropathy now. And the prevalence of kidney disease in diabetes is about a quarter. However, it's still the leading cause of end-stage renal disease in adults. It has slightly male preponderance, and it is strongly associated with poor glycemic control, but there is also some genetic factors, certain ethnic groups that are more at risk. Particularly hypertension can accelerate the degree of end-stage renal disease, a degree of nephropathy in patients with diabetes. It also takes about 10 to 15 years to see its peak. That, again, is about 25%. And with time, actually, it decreases. So if by year 20 or 30 of diabetes, the patient did not develop end-stage disease or kidney disease, most likely will not develop it, as opposed to neuropathy or retinopathy continues with time. And you see already in this old study that as the cohorts get younger, the incidence of nephropathy is lower. And if one were to put, again, the 70s or 80s, it will be even half of what it was in 1959. And that is, again, due to the better blood pressure and blood sugar control methods available. There is a clinical progression from microproteinuria. We use albumin as a marker of the degree of nephropathy. So the microproteinuria is the early disease due to hyperfiltration that occurs because there is a vasodilation of the glomerular arteriole, which is to a higher extent than the efferent arteriole, and so there is increased hydrostatic pressure leading to hyperfiltration and microalbuminuria. This state is early and can be reversible. However, if it progresses to a late phase, there is a decline in the GFR, and the albumin is now over 300 milligrams per 24 hours, and eventually the patient will end up with end-stage renal disease. It can take 8 years, 10 years, depending on other factors, but there is no reversibility at this stage. And by the time you have end-stage renal disease, you are either going to dialysis or you get a kidney transplant. The pathology of the glomerular disease may be diffuse, nodular, or mixed. The characteristic one is the nodular glomerulosclerosis, so-called Kimmel-Wilson disease, but you can have also diffuse disease, and I'll show you a picture. You have in both conditions marked thickening of the glomerular basement membrane. This is a normal glomerulus, and with the capsule of Bowman, the arterioles, and the tubules outside. And you see here the nodular, and you see with the arrow pointing to one of the nodules, nodular glomerulosclerosis, which are deposits of proteinaceous material, hyaline material, that are in between the arterioles. And this is an example of more of a diffuse glomerulosclerosis, not nodular. You see the whole glomeruli being covered with this proteinaceous material and thickening of the basal membrane, the capsule of Bowman in the arrow. And the more glomeruli that look like this, the more advanced the disease will be and the decrease of the GFR. How do you prevent that? And tight blood sugar control is the most important way to prevent the complications of all the complications we talked about today, but in particular the renal disease. And I'll show you the studies that prove that. Hypertension control, however, is also very important, particularly for kidney disease. When you have the first phase, the so-called microproteinuric phase, certain medications may help either stop the progression or actually go back to normal in terms of microalbuminuria. And these medications are the ACE inhibitors and receptor blockers. They're usually blood pressure medications. So quickly, we're going to go through the macrovascular disease. So this is not, these are the conditions of the big blood vessels. And can be associated, or can cause cardiovascular disease and accelerated atherosclerosis. Can cause stroke, can cause peripheral vascular disease, heart attacks. These are not diseases that are particularly of patients with diabetes. Microvascular disease are only seen in patients with diabetes. Macrovascular disease can be seen in any individual that has hyperlipidemia or hypertension, other risk factors. But the difference in patients with diabetes is that the risk is much higher and accelerated, and it can be seen at an earlier ages than patients who do not have diabetes. So the risk for cardiovascular disease in patients with diabetes is 2 to 4 times as compared to patients who do not have diabetes. And we mentioned what they are: the coronary heart disease, peripheral vascular disease, and cerebral circulation. And the prevalence over the past, this is a 10-year-old more slide, but it has not changed with time. We still have the same, as opposed to the microvascular that we showed that with time had improved. Macrovascular disease is still prevalent and equal over time, and it's about 25% for coronary heart disease in general for patients with diabetes. However, it does go up with age, and in patients who are over 75, over 50% of those patients will have some type of cardiovascular disease. So what do we do about preventing macrovascular disease? And we talked about how important it is to keep the blood sugar in good control. And has that been proven? Yes, it has been proven. And there are 2 major trials that you should know about. DCCT, or Diabetes Control of Complication Trial. The studies were finally published in 1993, and the UK Prospective Diabetes Survey, and that was published in 2008 or so. The DCCT was done in about 1,500 patients with type 1 diabetes, and the patients were randomized to tight blood sugar control, whatever was available in the 80s and early 90s to avoid hyperglycemia, or the usual control. And the usual control in those times was A1C in the 8s, 9s, 10s, as opposed to these patients that achieve blood sugar, an average of blood sugar with an A1C in the 7. And you know what A1C is, which is the marker of long-term control of hyperglycemia. UK-PDS is a study that was done in the UK on patients with type 2 diabetes. There were over 5,000 patients, and similarly were randomized to tight control versus usual control. And in this slide, you see the rate of retinopathy progression over time on patients according to their A1C. And you can see the A1C of 7 has a very flat rate of, and the lowest rate of retinopathy as compared to each percentage point increase. And when you have an A1C of 11%, is over 5 times the normal or the baseline rate of retinopathy. Similarly, for nephropathy, using microalbumin as the marker, you see that in patients who had intensive control over time, at 9 years, they have a decrease of about 50% in the incidence of microalbuminuria, which means nephropathy, as compared to the conventional control. And here, in terms of neuropathy, either primary prevention, so de novo prevention of neuropathy, or secondary intervention. That means patients had neuropathy, but were able to decrease the progression of it. So if you compare conventional in blue with the intensive in pink, you see that there is a decrease for both primary and secondary intervention of over 50% on patients who have better blood sugar control. So the overall results is a decrease of the onset of retinopathy in about 80% of patients, and the retinopathy progression about 50% of patients, nephropathy in about 50%, and neuropathy about 60%. With tight glycemic control. There was an increased incidence of severe hypoglycemia, but remember, these were the times where we have less available means to measure sugar and to treat different insulins. We have now better pumps, and this is much less of a problem. The UK-PDS, similarly, show that there is a decrease of about 25% of the microvascular endpoints with a reduction of the A1C in the tight blood sugar control group. The incidence of MI, or myocardial infarction, was decreased by 16%. That will be macrovascular disease, but this didn't reach statistical significance. So going further into the macrovascular complications, although there is a strong epidemiological data that's shown an association between poor blood sugar control and cardiovascular disease, so far the clinical studies that have targeted blood sugar control have not been able to demonstrate a decrease in the macrovascular complications, at least for type 2 diabetes patients. So when we talk about tight blood sugar control being so important, is for the microvascular complications. Although there is now some evidence on type 1 patients that may also favor the macrovascular disease, but not for the type 2 patients. So just to summarize, we've said so far, in terms of microvascular complications, that intensive therapy, and shown by these 2 studies in type 1 and type 2 patients, significantly decreases the microvascular complications. And I think that's all. Okay. Thank you. Any questions? Okay. Hey.
So I noticed one of your slides said that there's a 2 to 4-fold increase in cardiovascular events for people with diabetes as compared to non-diabetics. I was wondering how much of that is due to obesity rather than diabetes?
Right. I think that's an independent risk factor, but just looking at diabetes and taking away all the other, like hyperlipidemia, hypertension, are the risk factors that are part of the combination of type 2 diabetes, usually come with metabolic syndrome, taking that away.
Okay.
Just that.
Okay.
Particularly because type 1s, this is for type 1 and type 2s, and type 1s usually don't have that combination with type 2.
Right. Okay.
Okay, that's okay. That's okay. Yeah, okay, that's okay. Okay. And the time that you showed the first one's foot with the ulcer and the deformity is due to Charcot's is that due to ulcer is due to large vessel?
That also is more neuropathy than that.
Oh no, neuropathy. Okay.
I mean, I'm sure that person doesn't help the healing of it.
Okay.
But the initiation is mostly, usually the foot is where the person
You don't feel, and so they're prone to damage. Okay.
but in addition, the patient who has a sharp foot, they have, normally you have like three, right? The starts off, pressing here. But when you have sharp foot, there's all the forms that go much over. So then this, so you're walking on this. That's why you see
And that's
neuropathy.
you develop Charcot.
The sharp foot is the deformity itself.
Okay, that's fine.
The ulcer is because of neuropathy. So they are both